Hello and welcome to this fifth session of WAS Conversations. I'm Elna Rudolph. I'm the president of the next WAS Congress in South Africa in September next year, and I'm co-hosting this series with UMS from Nigeria, who's the honorary president of the Congress. I am so happy to be doing this session in partnership with FIGO, the International Federation of Gynecology and Obstetrics. And our topic for today is gender-based violence, a global epidemic. Please say hello to us in the chat. Please tell us where you are from. We've got a few hundred participants here today joining us on the webinar and more people joining us via Facebook Live. If you have questions for the panelists, please put it into the Q&A, not in the chat. In the chat, we'll be sharing lots of information with you, but please put your questions in the Q&A. And then I would just like to tell you about the committee that organizes these series of conversations. A lot of hard work go into organizing this and bringing these amazing panelists to you. So it's organized by the scientific chair Alan Jihami and vice chair Eric Janssen, and then the WAS executive, as well as the SASHA president, the South African Sexual Health Association, Anthony Smith. And then Marlene Wasserman, who is our moderator today, is also the local chair of the scientific committee for the next Congress. I thank you for all of your hard work and dedication to bring these sessions together. I would now like to introduce you to today's panel. If all of you can please switch on your cameras so that we can see you, so that you can say hi to everybody, please. So firstly, we've got the WAS executive. Pedro Nobre from Portugal is the president of WAS. Hello, Pedro. And then Esther Corona from Mexico is the vice president of WAS, and Luis Perelman is also from Mexico, and he's our secretary general. Then Marlene Wasserman is our moderator for today, and our speakers is Faysal El-Kak from Lebanon, Alex Iantaffi from the USA, Michal Luria from Israel, Claudia Garcia Moreno from Switzerland, and Lisa Vetten also from South Africa. We are so happy to have all of you on board, and I'm really looking forward to listening to your discussion. Let me introduce you to today's moderator, Marlene Wasserman from South Africa. Oh, Marlene, you had such a big task putting all of this together. Thank you for your dedication and your diligence, and that you kept on pushing until we got such an excellent session. We really appreciate it. So Marlene is the founder of the Dr. Eve brand. Everybody in South Africa knows her, and she's also known internationally. She's internationally trained as an ASEX certified clinical sexologist in private practice. She's an academic, an educator, international presenter, and a media celebrity with her own video and radio programs. But she says that she's most passionately invested in her clinical practice. She is an author of 4 books, of which Cyber Infidelity, The New Seduction is the latest one, based on her own research on the subject. As an activist and women's rights defender, she trains government and parastatal management teams in sexual harassment and gender-based violence. Find Marlene online at dreve.co.za, on social media, and in Cape Town and New York. And the rest of her bio I will put into the chat for you. Marlene, I hand it over to you.
Thank you, Elna. It's a joy to be here and to be representing the World Association of Sexual Health. So welcome to everybody from all over the globe on our topic today, gender-based violence, a global epidemic. And this is not a trite comment calling it a global epidemic. We at WAS, the World Association of Sexual Health, take this very seriously, recognizing the huge impact, the tremendous impact that this has on people's lives, women's lives, intersecting at every single level of their lives on a macro and a micro level. And in fact, this is obvious to those of you who I hope will read our Declaration of Sexual Rights. And I quote to you, what we say is that everybody has the right to be free from all forms of violence and coercion. In our Declaration of Sexual Pleasure, which you can also find in our chat box in the link, we once again state the possibility of having pleasurable and safe sexual experience free of discrimination, coercion, and violence is a fundamental part of sexual health and well-being for all. Today, the panel that we have is really unique. We have gathered people from all over the globe who will orientate you into a very different lens of gender-based violence. Each of them brings a very unique perspective on this very broad umbrella term of gender-based violence. I'm not going to give you their full bios because they're way too long and way too fabulous for me to not talk about them all. And I don't want to waste our fabulous intellectual capital by wasting time by giving you their full bios. Please find them in the chat box. I am going to introduce each one of them to you, and they will have their limited time to talk to you. So what we really would love for you to do is to have a conversation with us. Leave your questions in the question box and chat in the chat box. What I want to do is to introduce, first of all, as we begin, Dr. Faysal El-Kak. He's from Beirut, Lebanon, and he's here representing our partnership today with FIGO, the International Federation of Gynecology and Obstetrics. Faysal is going to talk about gender-based violence during COVID-19 when homes are not safe. He's the Vice President of FIGO, a senior lecturer of health behavior and sexuality in the Faculty of Health Sciences at the American University of Beirut. He's a clinical associate and director of the Women Integrated Sexual Health, the WISH program, at the Department of OBGYN at the American University of Beirut Medical Center. He's involved in providing clinical services, public health practice, academic work, and research related to women's health. Faysal is a member of the National Task Force of Lebanese Order of Physicians on Relief Work of Beirut Explosion, the technical advisor to UNFPA on sexual reproductive health relief work in Lebanon. He's got over 50 publications, book chapters, and a couple of books which are related to sexual, reproductive, and maternal health. I invite you to enjoy what Faysal has to bring to us. Straight after Faysal's presentation, we are going to be showing you a video which we think is really very important and very informative, recognizing or representing culturally appropriate intimate partner violence. This video was sent to us, thank you, Rihanna Raymond Williams, from her organization called Shine Aloud in the UK. Faysal, welcome.
Thank you very, very much for this introduction, and thanks to Elna and to all those who are organizing this fabulous, I'm sure, exciting webinar. We're very glad at FIGO to be partnering with WAS. My heart is in both places, as you all know. I welcome everybody in the participants, and I hope you will find this enjoyable, and we'll be happy to receive questions later on. Yes, I'll be talking about the when homes are not safe. I'm sure we all know that homes are not safe under COVID, but let's see together how this can be in terms of a global burden, and this is also what can we do as providers of care. This is some of us with Claudia also, she's among the panelists, announcing the FIGO stand on against violence against women. We all know that war and disasters, they bring a lot negative things to people under humanitarian crisis, displacement, and refugees. And at the same time, also, we know with this current pandemic and the previous pandemics, also it amplifies a humanitarian crisis, more so with the lockdown, with disease, dysfunction, and other problems. And that's why we find women, we in FIGO and also at WAS, we find women torn between two pandemics. The pandemics announced by WHO in March 2020, characterizing COVID-19, and the other pandemic also announced by the UN General Secretary, which is violence as a global pandemic. More so recently with the updated information on 243 million women suffering from, in the reproductive age, suffering from increased violence under COVID. You can see the numbers in France, Cyprus, and many other places in Latin America going up to 25 and 30% with the lockdown. Other data also from Asia, talking about increased rate of gender-based violence, which is pushing these governments and NGOs and societies to mobilize more resources to protect women from gender-based violence and from violence against them, mainly sexual violence under COVID. This is more in the most recent report from the Guttmacher Institute, data from the US, looking at close to, I think, 7,000 to 10,000 women. 16% reported having experienced some kind of intimate partner violence, whether a current partner or a past partner behaving in one of more of the following, being humiliated or emotionally abused, 11%, forcing women to engage in any kind of sexual activity, 5%, kicked, hit, slapped, or otherwise physically harmed, 6%, or making them feeling afraid, close to 10%. So globally, there is this whole notion of increased violence against women. More so with this recent also data from the Middle East, North Africa region, looking at 9 countries, 50% of respondents from these countries agree that women are facing increased risk of violence from their husbands or partners during COVID-19. This is data from these countries just to reported feeling unsafe at home, females and males, more under the lockdown. And also this is more and more numbers are reported. You can see the green, yellow, and the orange colors, meaning like more women are seeking care, whether with the justice or NGO shelter or family friends or others, and these numbers are increased by women seeking care in all these facilities, again, because of increased COVID, increased violence during the COVID pandemic. Specifically in Lebanon, we had 60% more women contacting helplines complaining of sexual violence and violence against women. To the extent that the US General Secretary, Guterres, in the past few weeks called for an urgent action to end a horrifying global surge in domestic violence against women and girls. But what are the pathways of risk for this? Probably we all know that there is a chance or there is a risk of this to increase. But what are the pathways? The pathways will start with a household stress from staying home, from close contact at home. This will lead or can be amplified by disruption of livelihood, like restriction to basic needs, restriction to money, access to health, other facilities, and also disruption of the social protective networks will make them more vulnerable, will have no access to service health they used to have, and lack of the essential support services. And all these pathways will ultimately increase the risk of women to be subjected to violence. How to respond? As governments, we have responsibility as health facilities and also as healthcare providers. We all know that violence is also a medical problem, can result in various types of injuries affecting women across her life cycle. This has been expressed in all the agencies that provide care, whether the FIGO, whether the International Institute of Medicine, whether the ECOG and the US Task Force. And our role primarily as agencies with healthcare providers is to learn and gain the skills to screen all, whether during the regular visit or during other various times, be able as providers to identify signs and symptoms that those women and young girls have been subjected to violence, whether by inside visit or through telehealth, which is becoming common also during the lockdown, and also to be able and have the skill to manage these cases in as much as we can, and also to refer these cases to where they have to be referred. This is a very recent editorial talking about violence against women during COVID-19, and it provided a list of resources that we need to violence against women. And all these resources are talking about the prevalence, they're talking about the incidence, they're talking about how to strengthen the health system and widen the service to integrate and include violence against women, how to care for women who are subjected to violence, whether a physical care, a counseling care, or a shelter care. And of course, we have worked a lot in my capacity as consultant to UNFPA and as FIGO on the guideline on the clinical management of survivors of violence, what to do in the clinic in terms of prevention of the unintended pregnancy, syndromic approach to sexual infection, and also when and where to refer to safe shelters for safety and also for legal counseling. At the end of my slide, I want to share with you, of course, these two persons who won the Nobel Prize for Peace. One is a survivor, an Yazidi, a survivor from the attacks by the terrorists in Iraq, and the other one, Dr. Magwiji in Africa, who has been dealing with the survivors of violence in the Democratic Republic of Congo. I hope you all join hands, like WAS is doing today, with FIGO to be able to reduce, combat, and help survivors of violence. And thank you very much for your attention.
I know he loves me. That's why we spend so much time together. I used to have a lot of friends and I'd be out every weekend. Dinner, drinks, raving, you name it, I was there. But since meeting Chris after the first year of uni, everything's changed. He's a bit older than me, but we just click. He says he wants me all to himself. It's only been 2 years, but I just know he's the one. Sometimes I bump into my girls on the high street. We start chatting and laughing like nothing's changed. But when Chris is around, the conversations are cut short. He says my friends are jealous of what we have, but I know they're just looking out for me. He knows I love spending time with him, but I've told him I need my space. My friends are just as important to me as he is. Whenever I talk about my friends, he always turns it into an argument. He'll say things like I don't care about him or I'm being selfish. He'll get really aggressive, say nasty things, storm off, and then he'll block me. I won't be able to get through to him, so I call his friends to see if he's okay. Within a few days, he'll apologise and say he can't live without me. He's been suicidal before, so I always worry. Things go well for a few days. We'll be on good terms, laughing and joking and back to spending time together. And then he flips out of nowhere and starts accusing me of cheating. He told me that his last girlfriend was abusive and she cheated on him a couple times. So I get why he's insecure. But after 2 years, I don't get why he doesn't trust me. I gave him all my passwords and logins, Facebook, Instagram, Twitter, Snapchat, even a login to my iPhone. He has everything. I thought he'd give me his too, but he says he's not really on social media like that. My friends say he's abusive and controlling, but he's never hit me once and he wouldn't dare to. I wouldn't say he's controlling either. It's my choice to be with him. Nobody gets him like I do. I really do love him. I just want him to see things from my point of view. I've just finished my degree. I want to travel, see the world, do exciting things I've never done before, meet new people. Whenever I speak about meeting new people, it brings it back to me cheating. I love him. I would never cheat on him. I'm really not sure when he'll get it, or if he ever will. We had sex last night. I didn't want to, but he did, so we did. It was the fertile day in my cycle. He's linked my Clue app to his phone, so he knows what days I'm most likely to get pregnant if we do have sex. This will be the 3rd time this month taking the morning after pill. I don't like the side effects, but I don't want to get pregnant. He thinks if I start using contraception, it will be an excuse for me to sleep around. He doesn't get that I'm just not ready to have a baby.
I think many of us can relate to, but I love him. And our next speaker certainly hears that a lot in their practice. It is with great honor, great pleasure that I introduce you our next panelist, Dr. Alex Iantaffi, who is in Minneapolis in the United States of America. Alex is a certified sex therapist, family therapist, somatic experiencing practitioner, clinical supervisor, author, and scholar. They are adjunct faculty at the University of Wisconsin-Stout and Antioch University, chair-elect for the Trans and Queer Interest Network of the American Association for Marriage and Family Therapy, and past editor-in-chief for the Journal of Sexual and Relationship Therapy. They have researched, presented, and published extensively on gender, disability, sexuality, relationships, and HIV. Alex is a trans-masculine, non-binary, bi-queer, disabled Italian immigrant who lives on Dakota and Anishinaabe territories, currently known as Minneapolis. Alex is the author of various books on gender and hosts the podcast Gender Stories. And I really do encourage you to follow their work, which is extensive and really important. Alex, welcome.
Thank you, Marlene, and thank you, WAS, for inviting me here today. I'm really looking forward to talking with you all about a little bit of a different perspective, which is talking about how the gender binary in itself is a form of violence that impacts a broad range of populations. And the reason why I want to talk about this is because often when we think about gender-based violence, we are thinking still in pretty binary terms. And actually the gender binary in itself is often one of the root causes of the violence that many populations experience. So I want to start from some foundational ideas. So one of the foundational ideas that I want to discuss is that gender diversity and creativity has always existed. And the pictures that you see on the screen at the moment is one is a picture of an effigy of the goddess, the Frisian goddess Cybele, was very popular across the Mediterranean, which is where I come from originally, and a statue of one of their followers, the Galli, who were usually what we would now call trans feminine people. So people who were assigned male at birth, but would dress in kind of feminine clothing. And we find this gender diversity and creativity all across the globe, not just historically, but also now. Gender expansiveness is really part of many lands, past and present. So you see a picture of the Femminelli, who still gather at Monte Vergine in Italy for the Candelora. The Femminelli are, again, people who are assigned male at birth and present as feminine. There's a picture of Hijras in India, and then a picture of the Two-Spirit, pride in the Bay Area. And Two-Spirit is really an umbrella term, which is Anglo-based, and it's a pan-indigenous term in North America, and it's inclusive of both gender and sexuality. So I'm going through this really fast because I want to get to the main argument, which is what does it all have to do with gender-based violence? Well, first of all, I want to talk about the fact that rigid gender binary is now taken for granted, and we think of it as scientific and foundational to much of the scholarship and the activist and clinical work that many of us are engaged in. And I want to pose to you that actually a gender binary is part of the ongoing settler colonial project and very much part of Christianization. And if you want to know more about why I make this argument and a little bit more than I can present in 10 minutes, there's a new book that I've just written called Gender Trauma, and I invite you to look at that. And one of the things that I talk about is how as settler colonialism started to really take over and erase many lands in North America and elsewhere, a rigid gender binary started to really take hold in the imagination of folks, and then started to become foundational. And I say in the imagination because as we look at science, more and more, many feminist scientists have really challenged whether a gender binary is scientific at all. And again, you can look at the work of people like Sari Van Anders and more to look at those arguments. So what does this all have to do with violence? Well, if we think about a gender binary as part of historical trauma, we know that historical trauma can manifest as higher rate of depressions, anxiety, substance use, alcoholism, suicide, and intimate partner violence and abuse. And if those statistics feel familiar, it's because often many marginalized populations are impacted by this kind of trauma. And in particular, I want to take a moment to really talk about how this impacts Indigenous populations where I live in the US. One of the impacts of the gender binary has been the loss of language and culture, including terms for a broader range of gender identities, roles and expressions, and loss of cultural, social, and spiritual roles for gender expansive people, but also two-spirit people. And again, that's a big umbrella that includes both gender and sexuality aspects, as well as broader Indigenous populations, really face higher rates of health disparity, including mental health issues, tobacco and substance use, higher risk of HIV infection, both in the US and globally. And of course, they also experience racism within broader LGBTQ communities, and especially fetishization of their bodies, just as all Black and brown people do, unfortunately, generally. Also, Indigenous girl, women, and two-spirit people in the US are at higher risk of exploitation and trafficking. And so generational and historical trauma is viewed as one of the most prominent contributing factors to the fact that they're more likely to be trafficked. And Indigenous women, girls, and two-spirit people are more likely to be murdered. And unfortunately, including dying at the hands of the police and due to police brutality, or just go missing. And those cases are really widely underreported. And the media often uses victim blaming language. So language that really doesn't put the victim in a good light. You know, it might talk about drug use or the victim in doing sex work and so on. And so almost justifying those missing and murdered bodies. And I would say that that is an epidemic in the US, an epidemic of violence. But this rigid gender binary doesn't just impact Indigenous population. I would say that it impacts all population in very specific ways. So I want to talk for a moment about trans and non-binary communities. And first of all, talk about how the communities that are most impacted, both in the US and on a global level, are generally trans feminine bodies. So that means people who are assigned male at birth and present and or identify as women. And usually Black and brown and immigrant trans feminine bodies are the most impacted, and Indigenous bodies. So trans and non-binary people are 10 times more likely than the general population to struggle with suicidality and are at higher risk of dying by suicide. They also experience higher rates of discrimination, harassment, physical and sexual assault, bullying in school, and refusal of care by healthcare providers. And there are also studies that show even at a young age, trans people, especially trans feminine people, are much more likely to be sexually harassed in a school environment by adults. And also deviating further away from the gender binary really increases the risk of encountering harassment and violence. And that is true for people of all genders. It's almost like really the borders of gender are really very digitally patrolled for everyone. I want to kind of move on as well to talk a little bit. I'm kind of just giving you a really brief overview because I want to give you a little bit of a flavor of how this rigid gender binary doesn't impact just one population, but many populations. For example, when we look at the intersection of Blackness and gender, Black women are 2 to 6 times in the US more likely to die of complications from childbirth, regardless of education or income. So this has nothing to do with systemic poverty, although systemic poverty is absolutely an issue for Black women in the US. And generally, Black people tend to be undertreated for pain due to healthcare providers holding implicit bias and really inaccurate beliefs about biological differences and pain tolerance between Black and white bodies. Black women's gender is also more likely to be questioned and closely scrutinized, which really shows the intersection of gender and race. And this also leads to higher rates of harassment and violence. And there are so many examples in the media of that happening to high-profile athletes. And Black people, including women and especially trans women, are more likely to be murdered by the police, die in police custody, or due to police brutality. And generally, Black, brown, and indigenous bodies are often hypersexualized while also being scrutinized for gender ambiguities and discrepancies. And this definitely leads to a higher level of intimate partner violence, police violence, social violence, and so on. So a few more facts about impact before kind of taking it all to its conclusion. Islamophobia also greatly contributes to global violence towards Muslim people or people perceived to be Muslim. And again, when we look at the intersection with gender, Muslim women are much more likely to be harassed or attacked for wearing visible signs of their cultural and or religious affiliation, such as the hijab. And several studies have concluded that gender conformity, which often entails the need for approval and validation from others, and we've seen a little bit even in the video that we just looked at, can negatively affect psychological well-being and hinder sexual autonomy. So in terms of WAS, if we think about the declaration of sexual pleasure, those rights to equality and non-discrimination, kind of a rigid gender binary impacts all of those negatively. And toxic masculinity, which we've seen very clearly illustrated in the video, also leads to poorer health for men. For example, research has shown that men are often less likely to seek and access healthcare, even when it's needed. And boys, especially Black, indigenous, and people of color, are also a higher risk of encountering violence at a younger age because they're looked at in a particular way because of their gender and race. So in conclusion, I really want to invite you to notice how our collective soma is really contracted around gender. It's as if we're all holding this collective breath and breathing as shallowly as we can, because of course we're afraid of what might happen if we let ourselves expand beyond those very rigid gender binaries. And it is not unreasonable given that gender expansiveness has historically been punished so severely. So I wish that there was more time, but there are some ideas of what you can do. And basically all of these ideas can be summarized as, please take a moment to really think about the gender binary, how it impacts you and the populations you work with, and make a commitment to dismantle it, because honestly, it is at the root of so much gender-based violence globally. So thank you so much for this time. And that's it. That's all I've got for you today. Thank you.
Thank you, Alex. Well, everybody who's here with us, I promised you a very unique lens, and Alex has certainly provided us a unique lens to be looking at gender as part of gender-based violence in this very unique way. And you will have opportunity to please ask questions to him. Just post it together with questions for the other panelists into the question box, and we will come back after we've heard the other panelists. It's with pleasure now that I introduce yet another lens of gender-based violence to you all, through the eyes of Dr. Michal Luria from Israel. Her topic is 50 Shades of Domestic Violence. Maternal health services, even routine gynecological examinations, can result in situations in which a woman's voice is not heard. What can we do to change this? So let me introduce Michal to you. Dr. Luria is president of the Israeli Society for Sexual Medicine. She's an attending obstetrician, gynecologist, and sex therapist. She's the director of the Center for Sexual Health at the Hadassah Mount Scopus Medical Center, clinical director of the Rotem Center for Multidisciplinary Sex Therapy in Jerusalem, Israel. She's a member of the Executive Committee of the European Federation of Sexology, and she's also the co-chair of the European Federation of Sexology Scientific Committee, chair of the Female Sexual Health and Dysfunction Subcommittee within the European Federation for Sexual Medicine, and a member of the Executive Committee of the Israeli Association for Sex Therapists. Dr. Luria, I hand it over to you.
Yeah, thank you very much, Marlene. Thank you very much, everybody, the organizers and the public in this virtual room for having me today. 1 minute. Okay, so the topic for today is obstetric and gynecological violence, which is a different view maybe not as extreme as the things that we heard about a few minutes ago, but still we are the people that are supposed to keep the women's health and well-being, and sometimes gynecologists are not aware of the power imbalances between patients and physicians, and that can bring situations of disrespectful practice. So I have a disclosure. I am a gynecologist. This is not a big disclosure because Marlene just told you that I am, but the things that I'm going to talk about are things that I've heard from my patients or seen with my own eyes. So there is this term obstetrics violence, which was coined about 10 years ago in Venezuela and talks about the dehumanized treatment by health personnel, the abuse of medication, and converting natural processes such as deliveries into pathological ones, causing to the loss of autonomy of women on their own bodies. So we are talking about rude treatment, disregard of women, pain. Women may say, I'm in pain, I'm in labor, and the staff may say, you're not in labor, go home. And then she can give birth in the car. She wasn't heard. She knows her body. She was talking and nobody was hearing her. Discrimination based on race, economical background, age, sexual orientation, or gender nonconformity. Denial of treatment, forced interventions. And for example, we know that in Mexico and Brazil, in the private practice, the C-sections rate is as high as 75%, which is much, much higher than the numbers that would be around 15%. Delivery can be traumatic, that we know that, but as much as 48% of women in some series may say that the birth experience was traumatic. And these women are not talking about a bad outcome, a healed baby, or a lot of stitches, but they're talking about physicians or midwives or nurses not hearing them, disregarding their knowledge, prioritizing their own agendas, lying and threatening in order to gain compliance. So this, as I said, this term is around for 10 years. And a few years ago, FIGO, in collaboration with another confederations and associations, they launched this initiative to promote active involvement by professional associations and governments to reduce abuse and neglect. But there's another topic we don't hear about at all, and I would like to ask you people out there, if we can have the poll question. How many of you or someone you know have had a negative experience at the gynecologist? Can you answer to that question? Okay, so I guess that we'll have the answer soon. Oh my God. Okay, 84% of you people have had a negative experience at a gynecologist or obstetrician. Okay, so I am surprised, in fact, but not very much at the same time, because unfortunately, we know that is the case. A survey that was done in Israel about 3 years ago, within 6,500 women, found that 47% of women found the examination, a routine examination, embarrassing. 35% said it was painful, 18% it was traumatic, 53% changed a gynecologist because they didn't feel comfortable, and almost 50% have had 5 or more gynaes in their lives because they weren't happy with the attention they were getting. So we gynecologists are taught how to look at the diamond, how to look at the cervix, at the uterus, the ovaries, the vulva, but we are not taught how to do it. What is the technique? How should we talk with the people? How is the woman doing? The woman that is there together with her organs. So gynecologists may not explain what they are going to do, ask the woman if she has had previous experiences. Gynecologists may not listen to what the woman is saying, may not cover the woman with a skirt or a sheet, may not offer a chaperone to be by her side. So I was talking at the very beginning about the power imbalance, which is always there between therapists and patients, physicians, healthcare providers, and patients. And because of this imbalance, patients find hard to speak up. Even intelligent and knowledgeable patients, they feel very small, very weak, and they don't speak up. And patients need to know that their input is valued and important, and the attitudes of both patients and clinicians need to change. And that's why this talk is so important. So the examination has a before and an after. And I want to ask if we have healthcare providers, gynecologists in the public, ask your patients, have you ever been examined before the examination? How was it for you? Are you concerned about any aspect of the examination? Is there anything I can do to help? And you women, tell the physician, I have been examined in the past. It was difficult for me. It was painful. Please do it carefully. Please explain to me, what are you doing? Before the examination, explain each step. I think that today, never, but today, less than ever, it's unbelievable that women lie down. The physician says, the gynecologist says, lie down. And the next thing she knows is the speculum is in her vagina. And nobody explained what is the physician doing. We should explain nothing should happen by surprise. And if it's uncomfortable, we should say, tell me if it's painful, I'll stop, I'll do it differently. We should give information which gives predictability, which gives control to the woman on her own body, then she can trust us. This paper was published 4 years ago. 4 years ago in Switzerland, somebody published that giving a skirt to a woman while she's being examined, that improves her experience. Isn't that unbelievable? So if you are a physician in the public, please offer your patients to be covered. If you're a patient, you ask your physician to cover you. If we should offer a chaperone if the person is interested in having a chaperone. During the examination, we should announce our next step and ask and receive permission before every step, and pick our words sensitively. Because I've heard of patients that have told me that the gynae would laugh at their pelvic hair, pubic hair, or the shape of her labia, jokes that maybe the gynae thinks are very funny, but they are not at all. Healthcare providers may not be aware of these details, or think those are not important, or think it's not part of the contract. I'm the one with the knowledge. I'm here to explain and to give my knowledge, and the patient is not here to give her opinion. So my ideas and suggestions is, if you have had a bad experience, or if you're a physician and you've heard of bad experiences by others, share these stories and create and increase awareness, like what we are doing right now. Make alliances. This woman that did the survey I was talking about at the beginning, she's a lady that herself she was pregnant. What I'm going to say right now, it's not a secret. Everything is written in her website. She was pregnant and with twins, and she was 25 weeks pregnant. She got to the delivery room. She said, I'm in pain. She was examined. They told her, you're not in labor, go home. And she gave birth in the car, and the babies didn't survive. So that was her trigger to begin this survey. And then she made alliances with some gynecologists. And at the end, the Israeli Obstetric and Gynecological Association wrote guidelines for respectful gynecological examination. So again, share your stories, make alliances, and if it works, do it again and again and again. Thank you very much.
Thank you, Michal. Another unique angle and another unique perspective on gender-based violence, something that perhaps we don't think about that often, the impact of a gynecological examination on a woman. This is interesting because it kind of loops back to Faysal's discussion as well around the role of healthcare providers, and maybe it'll come forward in the questions later on. We can discuss this as well. It was with pleasure that I introduce you to our next panelist, Dr. Claudia Garcia-Moreno, who is here representing, well, she is WHO, the World Health Organization, and one of the global partners of the World Association of Sexual Health. Claudia does magnificent work with gender-based violence in WHO. She currently heads up the unit on addressing vulnerable populations in the Department of Sexual and Reproductive Health and Research of WHO. She's got over 30 years of experience in public health and global health policy with a focus on women's health, sexual and reproductive health, and HIV/AIDS. She came to WHO in 1985 after 8 years with Oxfam UK and has led WHO's work on gender and women's health and violence against women, including coordinating the WHO multi-country study on women's health and domestic violence and co-leading the first global and regional estimates on intimate partner violence and sexual violence against women. Under her leadership, WHO has produced numerous guidelines and tools on integrating gender equality and human rights in health, strengthening prevention and the health response to violence against women, and the global plan of action to strengthen the health sector in addressing violence, in particular against women and girls. It's with pleasure that I introduce Claudia to you. Her topic is a global overview on sexual violence, the prevalence and health impacts. So welcome to you, Claudia.
Good morning, good afternoon, and good evening. I'm very pleased to be here. I feel that I'm taking you from the specific to the more general overview, but I do want to link to all the presentations, starting with Faysal's presentation on COVID. I think it's important for us to recognize that the epidemic or pandemic of gender-based violence and violence against women specifically has been here before COVID. It will remain during COVID and most likely, unfortunately, after COVID. And at the same time that we need to make sure that we really maximize the opportunity that COVID-19 has provided to enhance the availability of services for gender-based violence survivors, to engage with policymakers, many of whom are waking up to the realities of this problem, and also to really move forward on prevention. I wanted to start by thanking all of the men and women and gender diverse people who have really brought attention and raised awareness about the many forms of sexual violence and sexual harassment that many people face. And we really need to continue to ground our work in this activism and work that has been done. Next, please. I'm going to provide you with a quick overview on the prevalence. And I wanted to start by saying that gender-based violence is a very broad term. It means different things to different people, and it does encompass many different forms of violence. We've heard from Alex about some issues and from Michal. And at the same time, our knowledge, our evidence, our data is quite limited and doesn't cover all of the forms of violence. So we need to look at how do we improve our data collection. We've made huge progress in the last 25 years on data on intimate partner violence, a little bit less so on sexual violence, but there's still many forms of violence about which we have limited data, and that it's important to inform our discussions. Next, please. I also wanted to highlight that violence begins early. And again, violence during childhood takes many forms. And we have limited understanding of how all these different forms of violence over the life course interact with each other, and also the cumulative impacts of these violences on people's health and well-being. We know that, and there's a lot of evidence globally that abuse during childhood is linked to later experiences and or perpetration of violence, starting with peer-to-peer violence between children and adolescents, to bullying, to intimate partner violence, or rape and other forms of sexual violence. So really focusing on prevention of violence during childhood is something that I want to flag. Next, please. Sexual abuse of children and adolescents is highly prevalent. This is data from violence against children surveys from 5 countries. This is surveys that are being conducted by UNICEF with the Centers for Disease Control. And this is data from some of the countries in Africa and Haiti. And as you see, wherever we look, the rates are incredibly high. And this recent systematic review that looked at data globally shows that 18% of girls and 8% of boys had experienced some form of sexual abuse during childhood. Next, please. You can skip that one, thank you. This is just really to show that connection between experience of abuse during childhood and risk factors for perpetration. This is a study of men. Moving on to intimate partner violence, this is data from our regional and global estimates of 2013, and we found that globally, 30% of women had experienced at least one event, physical and or sexual intimate partner. We see in the map that it also varies by region, but even in the high income countries, it is 23%, so it's almost a quarter of women that had experienced this form of intimate partner violence. If we include also non-partner sexual violence, the prevalence goes up to 35%, so nearly 1 in 3 women. When we look at the prevalence of physical and or sexual partner violence in the last 12 months, so more recent or current violence, the difference between high-income countries and low and middle-income countries is much higher. High-income countries have between 3 to 6% of past 12 months intimate partner violence, compared to much higher in low and middle-income countries. And that reflects in a way the ability also to leave abusive relationships. Next, please. This intimate partner violence starts early. This is data from the 15 to 19-year-old girls, and we see that it's incredibly high. And we also know that several millions of women, of girls, are married below the age of 18, sometimes forcibly. And this issue of child, early and forced marriage is another form of gender-based violence that needs urgent action. Next, please. Moving to the prevalence of sexual violence, non-partner sexual violence, our 2013 data showed that it was 7.2% globally. And again, we see big variations. And I want to say that we know that this is a gross underestimate of the prevalence. This data came from 51 countries. we see a whole region from which we had no data, and we are in the process of updating these estimates. We hope to be releasing the new estimates very shortly. And on the positive side, we now have about 130 countries that have some data on non-partner sexual violence, but there's still many challenges with the data. Many studies do not disaggregate or do not include the type of perpetrator, do not distinguish between types of perpetrators. Some measure only rape or attempted rape, and a lot of the other forms of sexual coercion that we know are very prevalent are not measured. Some include sexual harassment and some not. And there's great variation in terms of age groups surveyed or studied. So a lot of a way to go still in trying to get better measures and trying to capture the full gamut of sexual abuse experiences from diverse populations. Next, please. We also know that some populations are at higher risk. We've heard already very eloquently from Alex on that, so I'm not going to go into details. But we know that this is true for people with disabilities, for indigenous populations, and for people of diverse gender or gender identities. And again, the data is scant and is limited and doesn't allow us to really capture the magnitude of these issues. And another issue that I want to highlight is the issue of early forced sex. A lot of girls in many countries report that their first experience of sex was non-consensual or was unwanted. And again, we have data that shows that this is linked to several negative health outcomes. Next, please. We've heard from Faysal about the increase of violence against women during emergencies, and particularly in conflict. This is also true for sexual violence against boys and men and gender diverse populations. Although the focus is very much on sexual violence, it's really also, we see that forms of violence like child marriage or harmful practices like female genital mutilation increase in certain emergencies. And the next one, please. And even at the height of conflict situations in Afghanistan, in Liberia, and DRC, women still experience largely intimate partner violence and violence from friends and neighbors. So important to keep this in mind. It's not just sexual violence. In the most recent study, this from South Sudan, really highlighted very high rates of overall experience of violence, with 1/3 of women and girls reporting experiencing sexual violence by a non-partner, and also 6% of men reporting experience of non-partner sexual violence. Next, please. Needless to say, all of these violences have major health impacts, including fatal outcomes. And for women and girls, particularly sexual and reproductive health outcomes, a strong link with unwanted pregnancies, abortions. We know that also particularly abuse in childhood is associated with high-risk behaviors that can in turn lead to higher risks of STIs and HIV. And in particular, we see major impacts on mental health, whether it's depression, anxiety, alcohol and substance use disorders. People who have experienced violence have been exposed to experience mental health problems. Next, please. And at the same time, we know that very few survivors seek or receive services. This is data from the same violence against children surveys that I showed earlier. And we see that of those children who had reported experiencing childhood sexual violence, the proportion that sought services was very low, and the proportion that actually received services was much, much lower. We also know that many encounters with the health system, unfortunately, are either missed opportunities, or they can be unhelpful, they can be re-traumatizing. Next, please, and I see Marlene, so I would wind up. The next, please. And this is my last slide. So in a way, this leads me to my conclusions and recommendations. Firstly, I think that we need to increase the awareness and the understanding of all healthcare providers about the importance of gender-based violence as an underlying condition or risk factor that is really relevant to whatever problem it is they're seeing, and to provide them with the skills to be able to provide, to deliver a survivor-centered response that does not re-traumatize people and that really respects their human rights and dignity. My second point is that we need to end discrimination in access to health services and in the provision of health services, whether it be on the basis of ethnicity, of class, or of sexual orientation, whatever it is. We need to ensure that all people have access to quality health care. And lastly, I want to say, emphasize the importance of data and measurement. We know that this is a big problem everywhere, even if we don't have the perfect data, but at the same time, we need to be able to name the problem. We need to be able to show the magnitude. We need to be able to promote and use this data for advocacy for prevention and for strengthening services. I'll stop there and I look forward to engaging in the conversation. Thank you.
Thank you, Claudia, for bringing us the facts that are cold, difficult to see and difficult to hear. We live with them all of us as healthcare providers. I also noticed, as I'm sure all of us did, the prevalence in Africa. And with that, I am doing a shout out to everyone who's with us online right now to come to Africa, to come to South Africa next year for our WAS 2021 Congress to be held in Cape Town and online, and to keep following us to learn more about that, because Africa needs you and we need you to learn from Africa as well. With that, I'm going to, before I introduce Lisa Fetton, I'm going to show you a video about South Africa. So sit back and absorb the cold facts of South Africa.
Another pandemic is raging in our country.
No time.
Freedom cannot be achieved unless the women have been emancipated from all forms of oppression.
And so says the voice of Nelson Mandela. It is with pleasure that I introduce our final panelist to you, Lisa Fetton from South Africa, Johannesburg. In South Africa, if you think about gender-based violence, one name comes up that you make a call to, and that is Lisa Fetton. She's an activist, a counselor, paralegal researcher, and she says an occasional draft of policy. She's worked for almost 30 years. She has almost 30 years extensive experience in the field of violence against women. Her current PhD seeks to provide a critical history of rape in South Africa. Currently, Lisa is a gender specialist on violence against women, appointed for the Commission of Gender Equality and the Gender V Project's impact consultant. And there's lots more to her CV, which you'll be able to read in the chat. Lisa Fetchen, I welcome you with great warm South African heart.
Thanks, Marlene. Can you hear me? Okay. Thank you. I want to pick up on what you're saying. I mean, you referenced the fact that my PhD is looking at a history of rape. And that's what I really want to start thinking a little bit about is how do ideas of history and space complicate and help us think more locally and particularly about gender-based violence? Thinking globally is obviously incredibly important. It's enabled us to spend our afternoon together, to be able to share and compare experiences. It also enables to give us a rich repository of information that we can gather around the world. But I think sometimes in the global, we lose sight of both the particular and the local and specific and historical, which means that we can sometimes miss the nuances of particular kinds of experiences. And that's what I want to really focus on today. And I'm drawing in particular on research in progress that I'm doing right now with the National Shelter Movement in South Africa that's trying to understand what happened in relation to women's use of shelters during the COVID lockdown. And I think it's in looking at this, we started to see a much more complicated picture emerging. I think very much there's been this emphasis on trying to find the number and to, I think, drive the narrative of the second pandemic. But I think in the focus on numbers, one has very much lost the larger questions of what is it that actually was happening to women during the lockdown in South Africa. And I think another group of women who've kind of been left out of this entire conversation, who I want to focus on, which is the women who are providing services. And here again, I think if you want to look at a broader understanding of violence, which some of our panelists have been doing, I want to look a little bit at structural violence and how that is gendered. And so in here, when I'm looking at the shelter services and talking about structural violence, I'm going to focus in particular on the way in which South Africa's social services are provided, because they create a kind of power structure that allows for a very particular and specific kind of set of power imbalances, inequalities, and violence. So I want to focus on that group of women who are trying to provide services during the lockdown when they were classified as essential services and were required to keep working, and what has really been their experiences under the worst stages 4 and 5 lockdown in South Africa, but as it's continued. So I think just to give a little bit of context, I think when South Africa's lockdown began, there'd already been attention paid to experiences in the rest of the world that had shown how increases to telephone lines had indicated there must have been a massive leap in experiences of gender-based violence around the world. We saw something similar in South Africa, but unfortunately, a lot of that came out of a misinterpretation by our police minister of the statistics at Gender-Based Violence Command Center. He announced that 87,000 calls had been received during the first 3 weeks of the lockdown, indicating this massive surge in violence. What he then had to apologize for was that those 87,000 figures that he gave were for all of the calls to that telephonic helpline for last year. But I think that statistic has stuck in people's minds and has meant that we've never been able to get to grips with, I think, understanding what has happened. And when we've found figures that present a somewhat different picture, it's presented quite a challenge in order to understand and complicate what has gone on. So one of the things that we find when we start looking at the shelters is that in some places, the number of women who came seeking shelter actually decreased. And that goes in line, I think, with the figure that we've seen from the police. It also suggests that reports to the police during the lockdown of domestic violence actually decreased in comparison to last year. And again, these are why it's so important to ask these questions of what happened. Because in probing more deeply around what happened, one can see that the state response in actually in some ways inhibited what could be done to assist women during that period. So one of the inhibiting factors was the nature of the permits. People were not allowed to move. And so in order to be able to move around, you needed to have a permit. One of the consequences of that was that women were often not able to leave, cross provinces and cross boundaries to go back to their families or to seek shelter elsewhere. So that was one way, I think, in which perhaps thoughtless response may have made it more difficult for women to flee. A second factor that started to become prominent was that the restriction on movement meant that some women, when they did go and report to the police, not always necessarily about gender-based violence, but about other forms of violence, They themselves then ended up being arrested and imprisoned and held overnight for having broken lockdown regulations. So again, I think an example of how one couldn't quite offer the help that one wanted to because of the state response. A third example, which actually resulted in a woman and her 7-year-old daughter ultimately being murdered by her partner, was the way the courts responded. And I think again, because there was fear of court workers of possibly contracting the virus, we found instances where in some courts, the clerks attempted to restrict women's access to court in order to obtain protection order applications. And this included things like saying that women first had to have gone to the police, to have been physically beaten, and to be able to show a police case number before they would open up or offer women a protection order. One could see that this resulted in one woman and her daughter being murdered by her partner. It was very clear from looking at the footage on the court security camera that she had actually gone to the court. One could see her arriving and then leaving, not getting her protection order because the court said she had arrived too late, she didn't meet the requirements, and her body was subsequently found 3 days later along with that of her child. So I think those all sorts of alert us to the fact that the state response was actually not helpful towards women. And I want to look at the third response, which is looking at what happened to those who are running the shelters. Now, so since South Africa's very first Department of Welfare was established in 1937, it has always been the case that the state has never provided social services in full. Services have always been provided in collaboration by some services by government departments, the Department of Social Development, and others have been contracted out to non-profit organizations who receive a subsidy in order to do so. With the lockdown, what happened was that it more or less coincided with the end of the financial year, so organizations were not able to sign their contracts and they did not get their funds in order to be able to provide services. What that meant, and this was very severe in one province in particular, was that because they did not get their funding, they were put in a position of for 6 months, and this applied not just to the domestic violence shelters, but also to child protection services, services towards older persons, who overwhelmingly tend to comprise older women, as well as services to people with disabilities. For 6 months, the organizations who ran those services and had to run those services in terms of lockdown regulations did not receive any funding to do so. So for 6 months, their staff either worked for free, took out bank loans until they had completely exhausted them, took out bank cuts, or had members of their family and friends trying to keep their shelters open. This, as you can imagine, placed enormous stress on the staff who are trying to run these services. They were responsible for vulnerable people, they were responsible for providing statutory services under the lockdown, and yet they had no funding to be able to pay themselves, to be able to even get to work, to manage and run their shelters, let alone to always be able to buy food to ensure that people were adequately, and women in particular, were adequately cared for. It took 6 months, a media campaign, a report to the National Director of Social Development in order to try to get things unlocked in that province. But it's gone even further. In that last week, one had to bring an urgent court application against the department to force them to pay those who had tried to provide services to older women under lockdown. Again, not a group that we necessarily always think about in relation to forms of violence. But in this particular area, 75% of those who use these services are older women who are looking after their younger grandchildren. They're amongst the poorest grouping in the country, and they depend very much on these particular service organizations to be able to be providing them with food. During the lockdown, because they weren't allowed to move, these organizations were not only ensuring that they got food by bringing them food, they were also ensuring that they went to go and collect their medication for them so they did not expose themselves to possible infection, being a high-risk group, and we're also providing frail care to, again, predominantly old women. Those who are providing the service are also predominantly older women. However, in trying to seek their payment from the department, they were told that what they had engaged in was fruitless and wasteful expenditure, that the state was not permitted to provide home-based care services to older persons during lockdown, and so they would not be paid. So I think and hence the need then to have gone to court to seek an urgent application against the department in order to compel them to pay this group of older women and their assistants for the service that they had provided to another group of older women during the lockdown. And I think the enormous hardship that organizations went through, the kinds of psychological stress, and we've seen this now in the shelters, where a number of the shelters, one of the things they've highlighted is the way they lost staff who found that they could not continue to work under this because of the stress that it was imposing upon them, that they began to become fearful of their own health and well-being in terms of having to use public transport in order to get to the shelter, that the shelter could not afford for them to have their own private kind of transport so as not to be exposed to the risk of infection in order to be able to travel to the shelter. So they lost staff, which meant that many people were required to work extra hours, shifts and overtime in order to be able to compensate for staff that they'd lost, or had to cut back on services, not provide the kind of service that they wanted to during this period. So I'm wanting to highlight this as, I think, as an example of a form of violence, and I'm calling it structural violence deliberately, because this was unnecessary hardship and suffering imposed not only on the group of women who were providing services, but those who were receiving services, put it in the way that the state responded. Now, arguably, I think many in government were being faced with this kind of decision, with this situation for the first time, did not necessarily know how to respond, and so one can allow, I think, for some trial and error along the way. But to deliberately withhold financing, to deliberately refuse to honor contracts, to make people try to, for 6 months, try to run a service is, I think, a structural form of violence. It was not necessarily recognized, but I think what I'd like to say in conclusion is that the pandemic opened up new ways and different ways of thinking of how violence can impact both primarily on the women who are exposed to violence, but perhaps more secondarily on those who are trying to provide services. And the way this then ensured that the other facets of the state response did not enable a supportive response to women during this period. So I think what I would like to say in conclusion is that, important as it is to look at the global, we also need to be looking at how do these things translate at local level? How do they manifest in particular and specific ways? And what does that mean for the kind of responses that we present? It needs to be historically informed and locally specific. And that might not necessarily fit neatly into attempts to, I think, create global definitions, but nonetheless within that particular historical and local context, are unquestionably forms of oppressive practice and violence. Thank you.
Thank you, Lisa, for that passionate discussion or passionate presentation, bringing in very personal stories, which is what the other panelists have really encouraged us to do. Michal, as well as Alex and Claudia as well, and Faysal, who really encourage us all to bring in personal stories. I think you all agree with me that we have really given you what we promised, a unique lens to orientate yourself towards gender-based violence. And the time that we have left, I'm going to read out the questions because it certainly has provoked really interesting questions from you, and I thank you for that. So let me start here, because each one of your discussions provoked really interesting questions. So here is a question from William J. Ugarte Guevara, who says, I think that obstetric violence is even worse in teaching hospitals or PHC, where either medical and nursing students are practicing. How can we improve this? So I guess, Michal, that would be something you would look at. And then also for Michal, have you found from Zia Wasserman, yeah, that's mine. Have you found that there is a difference between women's experiences with a female versus a male OBGYN? And I'm going to link that to a great question that Esther Corona asked similarly to that, where Esther said over here, she says, please would you comment on an internalized gender bias in many women who, even in the face of the evidence presented by Michal, still prefer a male gynecologist to a woman practitioner. So Michal, please weigh in, and all the other panelists, please weigh in. We want to generate discussion amongst everybody.
Well, thank you very much for the questions. Very amazing questions. So first of all, I think about if the university hospitals have a higher prevalence of obstetric violence. I don't know. I think it's a different style. Like private hospitals maybe have more C-sections. It's more elegant, like the woman is not hurt, but it's not, maybe she's not being examined by students. Like it's, I can't say because I don't have numbers and I don't have evidence, so everything is based on just intuition. But I'm not sure it's more prevalent, it's just different. I think it's different. I don't know what Faysal thinks about it. It's very interesting for me here, what you think about it. And just before, just another, like, I think men, I'm sorry, Faysal, and the men gynaes out there, but I truly think it's not evidence-based, it's just based on experience. I think men are more paternalistic with women patients than women, but I've seen women gynecologists being very rude as well, sometimes even worse than men. So, yeah.
Faisal, let's hear what you have to say.
Thank you. This is a very interesting point. I think we have to talk about it in 3 levels. The first level, it has to do, as Michael said, it has to do also with the policies we are practicing. In a tertiary, in a primary, there are existing policies that enforce, for example, the use of a chaperone, that enforce you to follow the guidelines in case you need an exam or not, you need this or not. So this is one level of doing it. The other level has to do also with the practitioner herself or himself and the environment of practice. And it follows all the guidelines and the assessment of this individual or not. And the third level, it has to do with the preferences, and that has to do with culture, it has to do with the previous experiences, and I'm talking about the gender preference of the provider. And I agree with Michael, having a woman provider or a man provider doesn't at all exclude or include or deny having this form of patriarchal. Although I share with you that there is more probably patriarchal inclination because of the nature of the medical sciences or medical school history as being a patriarchal way of doing it. I think if we have to send out a message and not to be like biased for a male or a female, I think the whole medical practice is a kind of a patriarchal form of practice. And in the absence of regulations, in the absence of policies and the practices, then wrongdoings might happen. In the absence of sensitization to women's needs and women's preferences, again, we're gonna have this. FIGO has a regular observations of this. We have a committee on ethics chaired by our good friend and colleague, Frank Shervanak from New York. And we keep on issuing statements, guidelines, regulations, reminders on the importance of prevention of structural violence, or if you want, setting violence that might be affecting women directly or indirectly, definitely. But this is something I think we have to keep in the spotlight and to keep on addressing, mainly, I believe, in the health setting and in the policies more than in the individual practices.
Well, this question, we've got more questions, but I'm going to move to Luis Perelman's question because I think we need to be covering other bases. And Luis says, how do we work with patriarchy and toxic masculinity to reduce gender-based violence? So all of you, please, will you weigh in with this question, which is kind of like a standard question, but really, really important that we do focus on it. I invite all of our panelists to talk to patriarchy and toxic masculinity. How do we work with that to reduce gender-based violence?
I can jump in there if you want, Marlene. Yes, that's like the work of a lifetime, right? I really think that we cannot challenge gender-based violence if we actually don't challenge the whole idea of gender as we've been kind of sold it wholesale in many ways. I think we really need to, you know, as I was saying, really look at what is it in the culture that tells us that men and women are so fundamentally different, you know, that there are such inherent differences. For example, if we look at masculine sexuality, you know, it's aggressive, always up for it. And we know as sex therapists, for example, how many issues that creates, what a role that plays in intimate partner, you know, sexual violence. We saw that in the video. And so I think it really starts at the root, really looking at kind of why are we so invested in cisgenderism, even as we do this research. you know, and we talk about those issues, we often keep perpetuating some of the same ideas, right? We perpetuate this really fundamental ideas that there are only two genders, which is at the root also of not just cisgenderism, but patriarchy. And that somehow, you know, women are victim and male are always perpetrators, which while it's true on a global level that is more likely, if we don't challenge the reasons why, right? There is a certain way, and Claudia, I think, was touching on this, that people are brought up. It starts before birth. You know, we come into cultural scripts around masculinity and femininity that create a lot of this really systemic power issues. Even when we're talking about in obstetrics and medicine, those are systemic power issues that cannot be dismantled until we dismantle the whole system, right? And that doesn't mean that gender shouldn't exist. It just means that we really need to see why are we so invested in perpetuating this very kind of Christian post-colonial, ongoing colonial, there is no post-colonial idea of gender, and I'll stop there.
Yeah, I know, I appreciate that, Alex, because I think that the way that we individually and as professionals need to be managing this is in a very microscopic way, by being infinitely aware in your own home, your own community, of these unconscious biases around gender, around the masculinity, the toxicity, the microaggressions that happen in conversations of everyday life. And I think we are not excluded as healthcare providers from being aware and teaching people how to do that. Okay, so I see that there are more questions, and Michelle.
Can I just add two words on that? I think that the other issue is to start, I mean, there's the structural gender dynamics, and then there's the individual and the family. And I think that there's a growing emphasis on the importance of comprehensive sexuality education that really promotes equality and equality in relationships and respect for different sexualities. And I think that that's an important agenda, as is the ongoing work, which is at a much smaller scale of changing, trying to change gender norms, working with young adolescents, and lastly, the media. I mean, one has to tackle the media because they really contribute, I think, in a very big way to this perpetration of gender norms. I'll stop there.
Thank you, Claudia. I have more questions here. I'm going to read one from Tim Sladden, who says, thank you to all panelists who've shown how diverse GBV adversely impacts both sexual and reproductive health. If we think in a life course approach where sex comes before reproduction, could be a stronger focus on protecting and promoting sexual health, well-being, and rights be advantageous for reducing all adverse outcomes. And then Corinne Ferreira Santos says, I'd like to know, please, how I can help as an OBGYN my patients in situation of intimate partner violence in an individual basis. I mean, how can I help them during the OBGYN visits? And this reminds me of something I wanted to ask Faysal, because he kind of raised it around how do you get an HCP to do the screening, and are they doing it? And if not, why not? How do we do that? How do we pick up? Because I don't know if there's much reporting, Elisa, maybe you know about that. Reporting gender-based violence when a healthcare provider does pick it up, any of the signs and the
Well, yeah, thank you for this, and thanks for the colleague also asking about this. FIGO is engaged in developing guidelines, some of them with the national societies, to acquaint and sensitize OBGYNs on how to identify any signs of violence. There are many guidelines also developed by UNFPA, and this will, and by WHO, of course, and this will guide the provider, in this case the OBGYN, how, with the opening questions and with the legitimacy of the questions around possible exposure to violence, and also providing the gynecologist with a reference list of how to refer, because your role will start and end in identifying and in managing. It depends if that's within 72 hours or after 72 hours, to manage the physical outcomes in terms of unintended pregnancies and sexual infections and so on and so forth. But then you will be able, at least through that list, to refer to shelters, to refer to the legal agencies or other agencies that the government or that country specifically is collaborating with in that regard. So at least as a GYN, you will have 3 skills: the skill to identify, the skill to communicate in the proper language, and the skill to provide the immediate physical care in case of reproductive, sexual, and even general physical health needs.
Well, let's hope that that happens. And so it is that we have come to the end of our session. I want to thank our panelists who were just superb. I think all the participants would agree that we really did, each one of you brought such a different angle, an important angle that touched and provoked everyone into much discussion. And I'm going to say goodbye and thank you and hand over to Elna to say final farewell.
Thank you so much, Marlene, and thank you to each one of the panelists. I think you deserve a virtual clap, and really, we have learned a lot from you today, and this session will be viewed by many, many more people in the time to come online on our various platforms. So thank you so much for your valuable contribution. And then I'd like to take the opportunity to invite you to our next session, which will be on the 28th of October. And the topic is sexual politics in the global South. It's chaired by Alain Duhamel, the scientific chair of WAS. And I invite you to come and join us and invite your whole platform also to join us. And the time will be exactly the same in South Africa, but with winter time in some areas in the world, it will be an hour later. So, it will be exactly the same in the rest of the world, but in South Africa, it will be an hour later, sorry. And then lastly, I would just like to invite you to South Africa in September 2021. We'll have the 25th Congress of WAS from 9 to 12 September in beautiful Cape Town. And South Africa has just opened up travel, and COVID permit, we would love to welcome you to South Africa. We are planning a hybrid solution for more people to be able to join us, but first prize would be to see you in South Africa, and to invite you there, I am just going to ask Michelle to play you a nice video from South Africa.
South Africa, a country on the tip of Africa, where the Atlantic and the Indian Ocean meet. Here you'll meet the biggest smiles of your biggest fans, all 57 million of us. You'll come face to face with the unexpected and be unexpectedly surprised. You'll meet great minds and you'll meet new ideas. Shed over interesting plates mixed with glasses of different opinions. You'll meet your dancing feet and your inner child. You'll meet inspiration at every single turn. You'll meet an energy unlike in any other place, in the very place where our humanity began. Come meet the biggest experiences of your life, and you'll meet a piece of yourself that will be forever changed. South Africa. Meet here, grow anywhere.
We look forward to seeing you in South Africa in September next year, and also at our next session on the 28th of October. On behalf of WAS and FIGO, goodbye.